is the fourth episode. We have already covered 3 episodes previously. And as you may be aware, I will be moderating this session. My name is Babu Karlum. I'm a Quality Inspections Officer with the Gambia Tourism Board. So, like I said in the introduction, we have successfully conducted 4 episodes on this series, 3 episodes rather, and this is going to be the fourth one. Of course, the recordings are always available on our Happy Hour series on YouTube channel, where you can view all the previous series. If you have any questions, comments, or contributions, you can share them on that channel and improving those things. You would definitely want to subscribe to this channel, as we would be bringing you more content to keep you informed and educated. So today's webinar focuses on case management of COVID-19 in the Gambia. And as you may be aware, we will be having our panelist, Dr. Njai, who will be taking us through case management of COVID-19 in the country. So every Friday, you can join us on this same channel where we will be discussing interesting public health topics. We'll be bringing panelists who are renowned experts in their fields of practice. So we give a little background as to who is Dr. Masiren Njai. He's a medical doctor in the COVID-19 case management team at the Edward Francis Small Teaching Hospital. Dr. Njai has a master's degree of medicine from the People's Friendship University of Russia, that's in Moscow. He's an associate member of the Royal College of Obstetricians and Gynecologists. Dr. Njai is also the registrar of obstetrics and gynecology unit at the Edward Francis Small Teaching Hospital. So you can see he is an expert in medicine, and obviously his expertise would be needed today to take us through COVID-19 treatment and management in the country. So this is our team as usual. From the left is Mr. Amadou Barrow from the University of the Gambia. You have Sir Umar Silla from the School of Public Health. Myself, Babu Karlum from the Gambia Tourism Board, and of course my brother Get from the School of Public Health. So today's agenda, we will be talking about COVID-19 situation report, a brief situation report. We would also do COVID-19 case management in the Gambia. And then we will have a question and answer with the panelists. I'm sure Dr. Njai is ready for all your questions. I'm sure there will be interesting questions with regards to case management of COVID-19. So the situation update as of today is Gambia has 28 confirmed cases, 1 death. No new cases has been registered as of today. But we are always interested in knowing what is happening in Senegal, and cases in Senegal are up to 4,759. And as you can see, the deaths are rising in Senegal, totaling to 56 deaths. Recoveries are about 2,994 recoveries. Tests conducted in Senegal stand at 58,179, and the case fatality rate in Senegal is 1.18. And according to the Africa CDC, their epidemic classification is in phase 3. So we'll take the next presentation, which is Dr. Njai's presentation. Dr. Njai, if I can share your presentation on the screen here, if that's okay with you.
Yeah, go ahead, go ahead.
Dr. Njai, you can take it.
Are you getting me? Yes, thank you very much, Mr. Lu. I guess, are you seeing me, or there's no need for that?
Yes, we are. That's okay. It's okay with us.
That's fine. Thank you very much. Welcome our viewers, our listeners. Are you getting me?
Yes, we are.
So I think all the others should put their mics muted, right?
Exactly. That's what we're trying to do right now.
Okay. Can we go ahead?
Yes, let's go ahead, Doctor. Let's go ahead.
All right, thank you. As you know, maybe you can go. So we're talking about coronavirus. We wanted to look at the case management in the Gambia. First of all, just a brief understanding of the coronavirus. We all know it's a coronavirus family. and it's an envelope positive RNA virus, just like HIV virus. Go ahead, next slide, please, or I can just do it myself. Next slide, please. Bloom, okay. So if you can understand that the reservoir of the virus is usually from birds, and it is believed that it has moved from human birds to human beings. That's where the most serious issue comes in. Next slide, please. Next. All right. So as we said, the transmission is from birds to human beings, and then the most interesting thing now is from human beings to human beings. We all are aware that this virus started in China, somewhere in Hubei provinces in around December, November, and then it has spread fast to other parts of the world. So what we believe is the virus does not have a leg to walk. That means either somebody take the virus for you, or you take the virus from somebody. So either you go for the virus, or somebody brings the virus to you. Sorry, I think I have some issues with my internet, sorry. So usually that is how the spread of the virus occur. So you're following, all right? Bloom? Okay, just wanted to make sure I'm seeing this slide. All right, so the next slide, please. So from human to human, we believe the transmission is through respiratory droplets. So when we say respiratory droplets, we mean either somebody sneezes or coughs on you, that's how you can get it. And even that one is not enough. It has to go through your mucous membranes. That is from the ear, the eyes, and the mouth. So that's where the mucous membranes are. So if somebody coughs or sneezes on you, the viruses just get onto your mucous membranes and get inside your body. And then also from the hand. So that means if somebody does not sneeze or cough on you, but somebody sneezes or coughs on somewhere surfaces where the virus has been shed, you put your hand there, you did not wash your hands, then you touch part of your mucous membranes, then you can be infected. So for just somebody to be standing 1 meter away from you, cough, it does not touch you, that does not mean you should be infected. So you can only be infected through your mucous membranes, that is our hands, which is going to take the virus from somewhere. We touch our eyes, our nose or ears, and then we get the virus. So unconsciously, how many times in a day do we touch our faces, our eyes, our ears all the time? So this we cannot count, and that is why the hands becomes very important. So that's why we have to always practice hand hygiene. Thank you. Next slide, please. The clinical presentations, as we said, usually most of them are asymptomatic, just like we have in the Gambia. Although some will be mild cases where they will develop some high-grade fever and some mild symptoms. Some will be moderate, and of course, at least 20% of the people will be severe cases. So when we say severe cases, we mean people who are going to have the severe form of the infection. They may have pneumonia, and then when they have pneumonia, that becomes complicated. So usually, as any other viral infections, respiratory viral infections, they just start as you just inhale the virus from the mucous membrane. It goes into your nose. They start having rhinitis and then sinusitis. Then eventually goes into the throat. You start having tonsillitis, irritation in the throat. It is not treated. It goes into the bronchi. It causes pneumonia and bronchitis as well. So you can see the virus travels from the upper respiratory tract infection into the lower respiratory tract infection. So in other cases, you have those severe cases where they will have a severe pneumonia, which can be life-threatening. So who are the people at risk of this infection called coronavirus? We mean the risk factors are, however, people of old age, 60 and above years old, people who have hypertension, people who have respiratory infections like asthma, TB, bronchopneumonia orally. So these people, when they have these infections, it becomes very, very serious. People with diabetic, sickle cell, or other immunocompromised diseases, when these people have this viral infection, it can be very, very serious. Next, please. Now, when the pandemic started, that the WHO declared it's a pandemic or even an epidemic in China, that the whole world was worried, the Gambia also, the Ministry of Health has not just sit down and fold their hands. We have to respond to a possible pandemic that is already coming. So what have the Ministry of Health done? They formed what they call the National Emergency Committee that was coordinated by the EDC. Now, under this committee, there are thematic areas that needs to be looked at. First, we have what they call the coordination unit, where both the strategic and technical arm is on the coordination unit. Then we have the rapid response team. So when you say the rapid response, it says whenever we have a suspected or a case somewhere, somebody needs to go there and see, is it true that this is a suspected case, and what do we need to do? So the rapid response team comes in. Then we have what they call the surveillance unit, wherein the contact tracing and the border surveillance, all the surveillance becomes under this component. So those are people who are going to be contact tracing, those are people who are going to be at the borders, those are people who are going to be at the quarantine. They form what they call the surveillance team. Then we have what they call the case management team. So now that we have a suspected case, rapid response went and confirmed that yes, this is a suspected case, the sample must be collected. When the sample is collected, that becomes the labs come in. So the labs have to collect the sample and go and test the patient. If the patient becomes positive, then we have the case management team coming in to take over and manage the patient. However, when the case management also takes over, we also need what we call the logistic security and safety component. Because in as much as I wanted to go to Basi and collect sample, or I wanted to take a patient from Banjul, Kanifing to sanatorium in Banjul, we need logistics, we need security officers, we need all those things available. Now, after that one, we also have what they call the risk communication and psychosocial group. So the risk communication is going to be the people, we need to have people who are going into the community and tell people, who are the people at risk? What are the risks associated with this infection? So we have the risk communication in the psychosocial. We all know the psychosocial impact of the coronavirus. So we have a psychosocial group that also is there set up to make sure that when people are deemed suspicious or people are confirmed, somebody needs to talk to them to make sure that they boost their morale, to build confidence in them and all those things. So these are the thematic areas that the Ministry of Health were put in place as a response to the pandemic as well. Next, please. Now, as we said, the surveillance units, we have what they call the active surveillance at our entry of points. So whenever, when this pandemic started, our entry points, our official border points, we have what they call active surveillance at the borders. That is both the land border, the sea border, and the airport. We have public health officials there to see anybody who comes into the country to say, hey, where are you coming from? Do you have any symptoms? No. But then if you come from the hot zone at the time, especially China at the time, go to their houses, they follow them every 2-3 days until the 14 days when they don't have symptoms, then they are allowed to go out. But when, however, when the border restrictions increases, when we close the borders, we say anybody who comes into the Gambia, we're going to take you for quarantine for 14 days. So that was all part of the active surveillance at our borders. Now, our health centers also, we know our country, our borders are very porous. So we cannot try to control everybody that comes into our country. It's going to be very difficult. So we know we're going to lose some people who comes in. So we say when they come, when they are sick, where do they go to? They go to our health center. So at our health center level, we must have what they call active surveillance at our health centers. When we say active surveillance at health centers, is to make sure that we triage people. We try to differentiate people who come from the hot zone, what are the symptoms they have, so that we know these people are the ones who are at risk or who are considered as suspect, and these ones are not suspect. So we make sure that all the facilities are doing that. We make sure that isolation facilities in all the health centers and border points we have in place. So in all our official border points, we have a holding room there. In all our major health centers and hospitals, we have an isolation room to say, if anytime we have a patient that is suspected, this is where the patient needs to go to be until the lab comes and collects the sample, until we confirm it's a positive case. So when they put patients in isolation, we call the lab, they come and collect the sample and take it to Fajara MRC, where testing was done. But now, however, we have the National Public Health Laboratories that are also doing the testing now. Now, apart from that, we also have a treatment center at the sanatorium. So you can see that if you look at the whole point, it's like now, we have the active surveillance going on. Anybody that is suspected, we put you in isolation room. The lab comes in, collect the sample comes out is positive. We have a place to take you for treatment. So this is how everything has been happening in the Gambia, and I think it is really paying dividend. Okay, next slide, please. Now let's look at the situation in the Gambia. As we said, we have 28 confirmed cases, of which one was dead. Now, most of the time, initially, the people who are at risk or who we suspect to have this disease were people returning from the Middle East and Asia, and later Europe comes in and Africa. Now, the reason why we put Senegal in capital, it means Senegal is our, how do I call it? Our greatest enemy or our greatest hotspot at this moment, because since now our borders are closed. Remember, when the borders, official borders are closed now, that means nobody, any person who is a Gambian or a resident of the Gambia, that's officially you are residing in the Gambia with your family, you went out, You want to come into the Gambia, you are allowed to come in, but you must have 14 days mandatory quarantine. So if you are not a Gambian, you are not a resident of the Gambia, you are not allowed in. Now we have Senegal in capital letter. That means Senegal is our hottest zone at this moment, because you cannot come from China without passing Senegal since our airport is closed. You cannot come from England, you didn't pass through Senegal, so Senegal is up. Now the interesting thing also is Senegal itself is having as much as 4,000 cases. So which means we are still not safe, and that is where the problem is. Interestingly, in the Gambia, about 80% of all the cases we have come from Senegal. And if you look at all the patients that come, most of them are even Senegalese who were residing here. They decided to go back home. So as I always say, COVID fight is like, it's a multi-sectoral. That means not only the Ministry of Health, the Immigrations Department, the Customs Services, the security forces, the community itself. These are all important in the fight against COVID-19. So Senegal now is our greatest enemy. And then now all the cases that we are having recently are all coming from Senegal. And this thing happens, unfortunately, even after the border closure. So something needs to be done about our borders. Now, some local transmissions, of course, happen. Few of them had a local transmission here in the Gambia. People coming from UK, and then people were positive from them. And then most of the local transmission, interestingly, are from people from Senegal. So we still have a situation that we need to deal with, and that is Senegal. So now if Senegal is not controlled, it's not settled, we are still in trouble. And this is what every Gambian must understand. Thank you. Next slide. Now, what measures have we done as a country to make sure that we try to combat this COVID-19, since we already agreed it's a pandemic? Now, we talk about what happens at the national level, but we have to also look at what happens at different levels of case management. We said, first of all the hospitals were forced, or the Ministry of Health set up what they call the Coronavirus Emergency Medical Team, which comprises of 14 doctors and 28 nurses with about 10 infection control people. So this team was comprised and set up to make sure that they respond to positive cases when they happen, and then sanatorium was identified as a treatment center. Now, what activities have they implemented? First of all, they have infection control measures needs to be in place. So in as much as we have this emergency medical team at the national level to respond to management, we must also have an emergency medical team in every major health center and hospital in the country. And all these people, the activities they carried out was to say infection control measures. We have to make sure we have infection control measures in all our hospitals. That is to say, hand washing station need to be provided, disinfectant, face mask, all these things need to be provided in our facilities to make sure we control the spread of infections. All activities that took place was the training of staff on IPC. In as much as you said, I must wash my hand, I must use, but you must train me to say, how do I properly wash my hands? How do I get this thing? How do I use the mask? You must train me on that. And these things has been done to say, okay, you want me to put on a PPE, you must train me how to put on a PPE. You must train me how to do mixed clothing. You must train me how to do proper hand washing. All these things were done in major hospitals and health centers. And then we have what they call active case surveillance. As I said, in all the major health centers and hospitals in the country, we have what they call active case surveillance. And when we say active case surveillance, it means at the gate of every major health center or hospital in this country, we have a triage system to say 1 meter away from every patient that comes in here, we have a nurse sitting down. When you come, the nurse asks you, what is your problem? At the time we say, okay, when the case definition of the WHO was, first of all, anybody who comes to respiratory illnesses to our facilities and had a history of travel or had a history of contact with somebody who was a suspected or a positive case. That was the case management, case definition we were using. So anybody who comes to our facility, we say, hey, where did you come from? Oh, I come from Italy last week. I have sore throat, I have, you say, oh, this is a suspected case. Now we say, as part of our active surveillance, it means tell the patient to wash his hands, give the patient a face mask, and take the patient to the isolation room. So when the patient goes to isolation room, now the rapid response will come, the lab people will come and collect the sample and take the for testing. That was part of our active case surveillance in our health facilities. Then we set up facilities to isolate and manage suspected. So which means every patient facility was armed as part of their training to say, a suspected case, this is how you need to manage. We say, put the patient in the isolation room, do the necessary things that are necessary. The lab will come on. If the sample becomes positive, the patient is moved to the sanatorium for treatment. If the patient is negative, the patient continues at your facility as a suspected case that you need to manage as any other respiratory or any other illness that you manage in your facility. Next. So as we said, the provision of disinfectants and water for hand washing on hospital entry points was part of the IPC activities. The new triage system, as we said, at the gate of every facility now, we said, before people enter into our hospital, we must know who are the people coming into the facility. Are they suspects or not at the gate of the hospital? And that's where the triage starts now. Now to say, if I'm in the triage now, somebody comes to me now and say, hey, I have abdominal pain. I'm seeing my period started yesterday. I have abdominal pain. You say, oh, this one probably is gyne problem, is this menorrhea. You say, okay, you go to the gyne. Somebody comes to you, say, I have a swelling on my groin. You suspect that this patient have hernia. You say, oh, go to the surgical unit. Somebody comes to you and say, I have toothache. You say, okay, this is toothache. Go to the dental unit. Somebody comes and say, I have cough. I have fever. You ask all this. You are asking travel history. Somebody say, I came from Italy 2 weeks ago. Now I have fever. I have cough. You say, oh, this one is a suspected case. Now, this one does not need to enter into the where people are going to enter. All what you need to do is to make sure that this patient is given a face mask, this patient has proper hand washing, and the patient is escorted to the isolation room. In that way, you are trying to avoid the patient having contact with a lot of health workers, other patients, and escorts in the triage system. So you make sure that these things are separated, and then that is how we're going to control the infection. I think one of the things that I always say, I was so happy after the training in Bansang, we conducted the training there, and then somebody came to Bansang Hospital at the gate of triage. When they interviewed the patient, they suspected that this one could be COVID because it came from Casamas. They just put the patient in isolation. And the patient then was, a sample was collected and sent. So the following day, sample came and became positive. So you can see that the active surveillance that we are doing in our hospitals works very well. Now, when this patient was positive, then the patient was transported to the sanatorium. So you can see that Bansang Hospital have done the triage system, the active triage system that we told them about, and it worked very well. So the only person the patient had contact with was the nurse at the triage that saw. And even that one was 2 meters away from the patient. So you can see, if you follow up those regulations, you are definitely going to be protected. So this is what we have trained most of our people. And we provided face masks and hand sanitizers to frontliners in various hospitals and major health centers. Next, please. Now, the training that we have been doing, we have done a massive training countrywide to say the target was staff identified for management of confirmed cases. Like I said, the emergency medical team that was identified to work at the sanatorium, that is the 14 doctors and the 28 nurses and other support staff that we identified. We are trained to say, okay, fine, now that we are suspecting, we are having a pandemic, we are expecting that we are going to have confirmed cases of COVID. We need to train them to say, this is how you protect yourself. This is how you are going to enter this place. What are you going to put on? How do you protect yourself? And then they were all training on basic infection prevention control measures and how to put on and put off PPEs. Now, not only the people who are identified as management of case staff, we said all other health workers in the country must be trained. And likewise, the training has been conducted in all the regions in the country, where we went and trained almost like 80% of the health workers in all the regions have been trained. To say, we said, okay, when we train you now, you go back and do a step down train for your people. Now, the reason being, if, example, God forbid, the 14 doctors that are already at the sanatorium all get sick, what happens next? Then you need another batch of people. So we don't want a situation where you say, oh, I was not trained, I'm not going to be part of it. But we had issues like that when pandemics break, everyone will start running away for their life. Initially, it also happens in the Gambia when these things started. People were trying to run away. No, I don't want to be there. My family said, I should not be there. I have this problem, I have this. So people have them. So you have to train more people to say, if all these people becomes positive, or my health workers that are working become sick, somebody needs to come in. And that is why all the other health workers in the country were trained. From Banjul to Kaina, we trained almost 75 to 80% of all health workers on COVID-19. Next, please. Yes, Lum, next. Hello, Lum.
Yes, I'm getting you. It seems I have a problem. It's a
okay.
technical. Just give me a minute.
All right, that's fine.
Baro?
Yes.
Baro, are you there?
Yes, I can hear you.
Do you have his presentation? It seems my laptop is frozen.
No, I don't have the presentation here.
I don't have. Okay, so let me just put on my laptop.
Okay.
Okay, what? Should I?
Yes.
Yeah, I'm sure people.
Yeah, Loom, you can kind of exit the
We got
screen.
it. We got it. You can continue,
You got
doctor.
it right.
Yeah.
Okay.
So can you go back one step? Go back. All right, go back. All right, good. All right, very good. So that's where we are. So the next slide, please. All right. So as we said, the active case surveillance, that is, we adopted the case definition from the WHO at the time. And as I said, the case definition that we were using at the time of the pandemic when it started was anybody who comes into health facility with respiratory illnesses, that is to say cough, fever, difficulty breathing, sore throat, and then have come from outside the Gambia at the hot zones at this time. So anybody who comes into the country with those respiratory illnesses, we said this is a suspected case. And these are the people who were isolated, tested. Now, as the pandemic goes on, when we started having local transmissions in the Gambia, this thing, however, expanded. So anybody now who comes to our facilities with respiratory illnesses, we should be testing. So in areas, sometimes we even say, okay, let's go and do massive screening, just like what happened in Bakau. So we'll have cases like that wherein we'll have people who will not have any history of traveling, but then they will have come with respiratory illness. You say, okay, now we're going to test everybody. Now everybody who comes into the Gambia is quarantined and tested. Everybody who comes into facilities with respiratory illnesses is tested. So this is how it is open now. It's not only depend on the travel history only. Now, we distributed, the adopted case definition was distributed in accidental emergencies as well. Active surveillance at the gate of all health facilities, and like I said, anyone with respiratory illnesses. Next. Yes, Lum. Okay, go back 1 minute, one step. Okay, go back one step. One step back. Bloom? No. We need slide number 14. Okay, here. So this is just an example at the Edward Francis Moore Teaching Hospital. If people who are familiar with the A&E will see that this is where the nurses and the medical students and house officers who are helping in the triage system sits. So you can see 2 meters away in front of them, the patient will come and they will ask the patient few questions to see why the patient is there. So if the patient fit the case definition to be a suspected case, then the patient is taken to the isolation room. So instead of entering the A&E and mixed with people, the patient is taken to the isolation room. Next, please. Now, this is like we said, this does not only stop at our public facilities, but even in private. This is one of the private facilities called the Buffalo Medical Center. If you can see on the right side, you will see a nurse sitting down there. And on the left side, you'll see a chair there. There's a small chair there. That's when the patient comes. If the patient sits there and the nurse sits here and take history. If the patient comes with respiratory illnesses, have a travel history, then we say, oh, you are a suspected. And that patient is taken right in front of you. There's a small room there. That's where their isolation is. So that means the patient will not even have contact with the general people there, the patients, the escorts, the health workers inside until the rapid response teams come in. Next. Now, isolation and management, we said all cases, all suspected cases identified at any contact point should be taken to the isolation. We already said that. So, but however, in our facilities, when people come and they are suspected cases, they have other illnesses. Like example, somebody comes to you, is a full-time suspect, but his patient is bleeding. You cannot say the patient is isolated, I'm not going there. No, you have to go and manage the bleeding or any other problem that the patient have. And now what do? We say management there. So that's the time you need a full PPE to go in there and see that patient. That is a very, very important. So we cannot say this patient is a suspected case and everybody try running away from the patient. We cannot do that. So when we have a patient that we said is a suspected case, the patient is taken to isolation. There are management protocols that need to be followed. Next, please. Now, as we said, confirmed cases are sent to the UFSC sanatorium for further management. So we'll talk about the management at the sanatorium as well. Next, please. Okay, like the management protocol, like we said, first of all, we said infection control measures. So we said we have to make sure that we follow the infection control measures. That is one, use of medical mask. If you are working within 1 to 2 meters of the patient, we have to place patients in single rooms, or we can group them together, those with the same etiological diagnosis, in close contact with the patient with respiratory symptoms. So if a patient is coughing or sneezing, you have to use eye protection, that is face mask or goggles as well. Next, please. We make sure that we limit patient movement within our institution. If we say this patient is suspected or is a confirmed case, the patient is taken into the room. We should next make sure that the patient should not be walking from one place to the other. We should limit their movement. And we use PPE when entering the ward and removing PPE when leaving the ward. So when we have a patient that is suspected, we must make sure that we must put on a PPE when we are going there. Now the equipment in that place. Now, if we are going to use a stethoscope, a blood pressure machine, a thermometer, or any other thing, you must make sure that it's a single use. That means it's used for only that patient in that room. So we cannot use the stethoscope or blood pressure machine for a patient in one room. That is a suspected case, we don't know yet, and they go to the other place and use the same thing on the same people. It's not, that is advisable. That is not advisable at all. We must make sure that they are used or they are sterilized or disinfected before we put. We have to make sure that we ensure that health workers refrain from touching their eyes, nose and mouth with potential contaminated gloves or ungloved hands. So as we said, the mucous membranes were the things that are more where the virus enters in our system. So we must make sure that we try as much as possible to make sure that we do not touch our eyes, nose or mouth during attending to these patients. Next. We avoid contaminating environmental surfaces that are not directly related to a patient care. Now, if I enter the house, I'm just there to, the isolation room, I'm just there to collect the sample. Let me just collect the sample and go. I have nothing to do with other areas. We must make sure that we do not do that. We must ensure that we have adequate ventilation in the rooms. Now, avoid movement of patients or transport, perform hand hygiene, apply airborne precaution when performing aerosol generating procedures. So if we are performing aerosol generating procedures, intubations, nebulization, we have to make sure that we do airborne precautions. A full PPE must be put in to cover our faces and nose as well. Next. Now, probably this was an issue that we had, so we have this table from the WHO website to say who are the people who need the full PPE in, who need the face mask. Because initially when these things happen in the Gambia, you go to Westfield, almost everybody was selling masks, everybody was doing that. We had issues with some health workers. Nurses were saying, no, we are not going to do this, we are not protected. Some health workers were saying we are not protected. The question I always ask, what kind of protection do you need? Because if a nurse is in Bansang Hospital and said he needs a full PPE to protect himself just to conduct antenatal clinics, now let's give him a full PPE, full gown PPE, put it on and go and see the antenatal. Within 10 minutes, nobody's going to tell that person, come and remove this. So people have to understand what kind of PPE do we need. We say PPE, personal protective equipment, is inclusive of everything. Now we need to know what do we need in a particular area. If you are at the triage area at the gate of the hospital, wherein you maintain a 2-meter distance between you and all the patients, do you need a full PPE? No. All what you need is just a face mask and make sure your hand washing properly. That's all what you need. Now, if you are going to do aerosol generating procedure, then that's the time you need a full PPE, eye protection, apron, gloves, gown, everything you need to put it on because you do not know what you are trying to deal with. However, other areas because I always wanted to healthcare workers. Now, the use of face mask, we have to understand the use of our medical mask. Anywhere we see, we have to always contextualize the issues. Now, in the Gambia or anywhere in the world, if what we were seeing in the Gambia before, that everybody was in mask, suddenly it disappeared. But initially, everybody was using mask everywhere you go. Now, if everybody in the Gambia who wants to use mask wants to come to our hospital and say, I need a surgical mask, can we please maintain this? No way, we cannot maintain this. So we said the people who need our medical mask are the healthcare workers who are taking care of patients and the patients who are coughing. So if you have symptomatic patients who come to your facility and the people in the facility that are working with the health worker with the patient are the ones that need our surgical mask. Now we cannot be giving everybody surgical mask to wear, so we cannot provide. If anybody wants to use a mask, you're allowed to use a mask, but not the medical mask that we use. You can use the cloth mask to protect yourself. Anywhere you are going where there are going to be many people, you can try to use the cloth mask, but not the surgical. Lum, are you getting me? Hello?
Yes, Dr. Njai.
All right, somebody was just calling in, so I thought, but you are getting me, right?
Yes, I'm getting you.
Yeah, so let's move to the, okay, like the triage system. Look at the last screen. We said health workers who are doing triage at the initial stage, you have to make sure that you maintain at least 1 meter distance between you and the patients, and you must have a face mask to protect yourself. So basically, these are the things that we wanted to emphasize, that not everybody in Nigami should be taking our medical masks from our hospitals and putting it everywhere. So it should be reserved for the healthcare workers in the facilities and the people who come to the facilities with respiratory problems. These are the people who need our surgical mask. Next, please. Next. Are you there?
Yes, I am. Just a minute.
All right.
Yes.
Okay, so as part of our training and these things, we have been training, well, that was, we have to have done that, but that's okay. That is the putting on of the PPEs and putting it off, which is very, very, very important for anybody who's going to work in terms of managing this COVID patient, either it's a suspect or confirmed. Now, just to add on to the positive management cases in the Gambia, unfortunately for us, all the cases that we have in the Gambia were asymptomatic. I think about 2 or 3 people had mild symptoms. To put them on that one on ceftriaxone, which brings the fever down. So apart from that, all the patients that we have here are asymptomatic, and we are not put on any medications. Initially, we had one patient we put on azithromycin and chloroquine for 3 days, and then later stopped. But all the others, nobody was on any management. As we all know, the COVID virus still have no treatment or cure in the world still now. Well, vaccines are already on trial, but there's still not a proper, definite cure for it. So what we do is we manage their symptoms. The patients we had in the sanatorium, I think about 2 or 3 people had mild symptoms. One had fever for more than 24 hours, up to 48 hours. Then we end up, after the paracetamol did not work, we started him on IV ceftriaxone, and then later the fever comes down. We had one who has mild cough with cetirizine. She was fine. The other ones are all on, some of them were not given any single medications there because they do not have any symptoms, because they were all asymptomatic patients. So basically, that was the situation in the Gambia. So thank God, we do not have anybody who needed oxygen. We did not have anybody who needed intubation, which is a blessing in disguise. I think that everybody have to be happy with. However, as I said, the putting off PPE and putting off is something that we can all probably look in YouTube and have an idea about. And I think I don't need to go over that drill. Probably that's the next 2 slides. Go to the next one, please. I think the next slides are all about the PPE, putting it on and putting it off. Yes. So all the other ones are about PPE, which I don't think we need to waste much time there. And I think most of it, basically that's the presentation. And the last 2 parts can just get to YouTube and have an idea about it. On that note, I thank you very much for your kind attention. If anybody have questions, we can go back to question session. Thank you very much.
Thank you very much, Dr. Njai. I think the presentation was very useful. It was very short and precise, straight to the point. I think we would go ahead with questions if we have any. So all the participants can share their questions in the chat box, and then we will take them as they come in. We, however, have a few questions from our WhatsApp group, and then we will take them one by one. Okay, and the first question is, what is the treatment protocol or regimen for COVID-19 cases? Currently, what treatment regimen do we have for cases in the Gambia?
Yeah, so like I said, we do not have any treatment regimen for now because all the cases that we have in the Gambia were asymptomatic. So, however, we had a plan to be starting them on azithromycin, which is a wide range antibiotics that we all agree on. And initially, there was a lot of studies where we are going on use of chloroquine. So we were having, as part of our initial protocol, chloroquine and azithromycin, but because we do not have any patients that were severe, so we did not start we start only one patient on azithromycin and chloroquine. So basically, that is it at this moment. We don't have any patient, and that's why we are still not having any definite treatment protocol for anyone. But however, if they have fever, we give them the paracetamol. If they have cough, we give them some cough suppressants, and that's all.
Okay. The next question, I think you mentioned this in your presentation. That's
Yeah.
the question raised: what were the most critical cases seen, and what is what is attributed to this? What are the underlying factors for those patients?
Yeah. So I said, like I said, we always thank God that we do not have any critical case. Just the only thing I was saying, like somebody was the high grade fever of 39 degrees for more than 24 hours. I think basically that was the most critical we can call it. But apart from that, we do not have anybody that was critical that we think maybe we need extra care. Yes.
Okay. The next one is, what is your professional opinion on the studies that were conducted on hydroxychloroquine? Says at some point the WHO said it was not safe, but later revised the decision. What is your professional opinion on the use of hydroxychloroquine?
Yes, so I cannot say much about that because I do not know much about the trial. And probably those doctors in the areas where the trial were conducted will be able to shed light more on those ones because we do not try it here, we don't know. And then the other thing was there was this issue of the effect of hydroxychloroquine on cardiac output. So there are a lot of rumors about it being one of probably the core cause for some of them dying because they have realized that most of the patients who are going into ICU in other places were not coming out. And some were attributing it probably with the use of hydroxychloroquine. I'm not sure because we did not conduct any trial here. We don't have any experience in the use of hydroxychloroquine. So I don't think we can say much about here. But usually what we have in the Gambia in fact is chloroquine, not hydroxychloroquine.
Okay, very well.
Yeah.
The next one here is, I think this one is in relation to reports that the Madagascar drug, I don't know if they call it Malagasy, there are reports that a consignment of it was received in the Gambia. Yes. Is this information correct before we go further into the second part of the
question? Yes. There were some few doses that came in. But however, as I said, our health system also, we also are not just sitting down and just like that. We also have to follow protocols. So we did not use it in the Gambia yet, and I don't think we probably is going to use it because we do not have any cases where we say these are severe cases that we need to use the medication for. So for now, we have not used it still now at a government level. Yes.
Okay, very well. That answers the second part of the question because the guy was asking, is there any plan of using it?
Well, for now, no. There is no plan yet now for now.
Okay. The next question is, does the case management team plan to use the newly refurbished Demban?
Yes.
Hello?
Yes, I'm here.
Yes, the question reads, does your team, that's the case management team, have any plans of using the clinic, I believe the Ndemban?
Yes. We have plans if the need be. Unfortunately, or fortunately for us, we do not have that surge because as I'm talking to you now, we have only 6 cases on our care at this moment. So all of them are symptomatic, they are stable. So sanatorium itself can take up to about 40 people.
Okay.
So if the sanatorium, God forbid, sanatorium is full, then we have to move into Ndemban. That's why Ndemban is for fish.
Okay.
And then there is they put oxygen, they put almost everything. I think we have to use the opportunity to thank Mustafa Njai and the team, Staff Global, for their wonderful job there as well. So if the need be, of course, to be used. Is the second.
All right. So the next question is, in a clinical perspective, why are...
Yeah, so this is a question that we have all been asking. Initially, when we all heard about the pandemic, and then we were prepared from our mindset, and then from all perspectives, the way we were prepared and the way we saw it here is different. Now, I'm not sure the stereotype or which kind of stereotype we have in the Gambia, but I believe probably maybe it's the mild one, because even in America and other advanced world, they have mild cases, of course. But someone will say, we were thinking, is it that we have a very mild part of type of the virus that is in the Gambia one, or two? Is it that we have younger people? Because I think the highest, the oldest we had was 83, and he also recovered. So it was like, but then when you look at the age, you go to other parts of the world, same people younger than that are dying. So I mean, it becomes a debate to say, actually, what is the case? But for me personally, I think I believe like we might be having the non-virulent type in the Gambia, which means the type we are having here is not very, very dangerous like the ones we are having in other parts of the world. Because what we were hearing from the West and when we were preparing for these things and what we saw is definitely different. Okay? So you can see others, we don't even give them anything, will definitely recover, which happens in other parts of the mild cases.
That would be my next question before I hand over my colleague Omar's questions on the chat, because we're seeing most like about 80% of cases with mild symptoms or sometimes with no symptoms at all. In other countries, we realize that they are doing home management or home isolation.
Exactly.
Why is this not the case in the Gambia? Why are we not asking them to sit at home, but rather would prefer to take a treatment center?
No, so now you have to also look at our social social well-being compared to other parts of the world. Now, if you go to America, UK, and other places, probably you have a man, a wife, 2, 3 children, not more. Even when their parents, when they are old, into home for the elderly, isn't it? In the Gambia, example, in my house, in my compound now, we have almost 10 people living. So if I'll tell me to go and isolate myself at home, it will be difficult because my boys will be joined there, my wife is there, my mother is there. So these are things that are good. And well, we thank God that things have not gone to that. But probably if it has gone that far, he will even be preferring to go and check where does this person live. If they live 2 or 3 people, he or she can isolate, self-isolate. Then we allow that because economic of this isolation also is so much on government also. Somebody is taking the that is definitely a very big economic burden on the government. But thank God we have not reached that point where we cannot put them in one place that we have to allow them to go. We have not reached that. But because of our social well-being, that's why we do not allow people to be self-isolated at home, because it's something very, very difficult from the Gambia.
Thank you very much, yes. Dr. Njai, for your professional perspectives. I think the questions have been well answered. My colleague, Omar Silla, has informed me that we have questions on the chat room, and then I will allow him to do those questions before we allow our participants. We will unmute everyone to come in with their questions, contributions, and comments. Once again, thank you very much for the wonderful presentation.
Thank you.
Thank you very much. Yes, Loom, I am here. Thank you very much for that beautiful moderation. And Dr. Jai, thank you very much for that.
You're welcome. You're welcome.
I will take some questions on the chat, starting with Ibrahim Abaro. Okay, Ibrahim Abaro's question, I think, is answered. He's asking about, are we using the Madagascar drugs at our treatment center? If not, why? I think that is almost answered. But do you want to have a reflection on that quickly for him? Why
is that what?
He said, why are we not using the Madagascar drugs at the treatment center?
Yes, I answered that. I said we do not have any severe cases in which we have to use those medications. So because now somebody does not have symptoms, and that's why if you are all following the media, most of the patients we have in the Gambia were making a lot of noise, even at the sanatorium when they came first. They said, no, I'm not going to take treatment. I'm not sick. I'm not that. So somebody said, I'm not having symptoms. I'm not having anything. You go and give that person the Madagascar drug, probably it causes diarrhea, it causes something. You say, oh, you see, you have caused this thing to me. So you probably have to give those treatment to people who you think are sick, and you put the options to them to say, this is what we have here, and these are the possibilities that we can have. So if the patient accepts, of course we give, but if the patient doesn't accept, we don't give. So I don't think we have come to a point where we need to use those ones. Thank you.
All right, so the next question is from Lamin Jadama. He's asking, how are the asymptomatic carriers coping with the stress of COVID-19?
Oh, well, it's something that we have been expecting. Sometimes we see them when they come, they start complaining that no, I'm not going to be here. We had one who said, in fact, he's going to commit suicide. But that is expected, looking at the stigma surrounding the COVID-19 worldwide. That is something that we were expecting, and it was not. So that's why we have the psychosocial team that are already stationed and waiting to come and talk to them. So when we have those things, we call the psychosocial team who comes and talk to them. Initially, in the first 2-3 days, it's very, very difficult, but as time goes on, they cope well. They cope well.
Next is from Abdullah M. Sanyang. He's asking, how do the case management team reunite the discharged patients with their families or relatives, looking at how positive cases become negative and vice versa?
Well, I think I'm not very sure to cope with their people, but that is not something very difficult because, as we said, even in the West and other parts of the world, the COVID is, people recovered well faster than each other. Some people will go, just like I always tell people, you will have a road traffic accident, somebody will die, other will go for road traffic accident, he will not die. So this is something that people have to understand. It does not mean if all the people who are having this has to be intubated have to be sick, severely motivated. Then they will recover very, very fast, and then that happens, stress, stigmatized, and all those. But eventually they overcome it and then cope with it very well.
So the next one I'll take from Sang Fatima Mendy. Sang Fatima Mendy is asking, how do we manage visitors entering our clinics as they are not patients?
If you are following presentations, one of our active management or as I said, the infection prevention control measures was to make sure that we do not have any visitor in the hospitals now. So we say anybody who is admitted in our major hospitals now, we say we only allow one person with you, that's your escort. So we do not allow visitors to come in. So as I said, the virus does not have a leg to walk in. Either you bring the virus to me, or I go and pick it from you. So to try to minimize that, we say, okay, no visitor comes into the hospital. That's one of the measures we do. So the only people that will come is the escort of the patient, and that is only one person. Basically, that's how we control the visitors. But as you all know, Gambian culture, it's still very difficult to control people sometimes.
Second from the last question is from Yaya Nancy Kande. Yaya is saying, thank you, Dr. Njai, for the wonderful presentation. Now he's asking, in your presentation, you mentioned that visitors must be given gowns and gloves before they are able to see the patients. Considering we have limited supply of PPEs, will it not be wise to reserve those PPEs for only the health workers?
No, maybe he did not get me properly, or she did not get me properly. I did not say we give PPE or gowns to our visitors. I did not say that.
Okay.
We cannot give that to our visitors. Or maybe if I said it, it could be the slip of the tongue.
All right. So the last question I have on the chat before I hand you back to Mr. Babakar Loom is from Ibrahim Barrow. He's asking, is treatment center testing discharged patients few days after the discharge, considering possibility of reinfection?
Well, usually at our treatment center, because before we discharge, you must have two negative symptoms, two negative lab results. So usually before we discharge them, as I said, they're all asymptomatic usually. So when you check them, they are negative. You check them again, they are negative. You discharge them. So the contact tracing team, that is what follows them up from after the treatment center. So they're handed over to the contact tracing team, who follows up their case from the treatment center.
Thank you very much, Doctor. Back to you, Loom.
Thank you very much, Umar Silla. Doctor, before we allow our participants to come in and ask or contribute, I just have one final question. Do we have the capacity to take care of severely or critically ill patients?
As of now, yeah, I can say yes, because we have CPAP machines, we have ventilators at the sanatorium. Thank God we did not use them yet, but we have about, I think, 3 or 5 ventilators at this moment, with 2 CPAP machines also available.
Thank you very much. That is very much reassuring. Amal Baro, if you are with me, can you please unmute the participants, and if they have any questions or comments that they want to share with Dr. Njai and the rest of the audience, they can do so, please.
Yes, thank you so much, Mr. Loom, and of course, Dr. Njai, for that very, very elaborate presentation. So, like we said earlier, the floor is open, and anybody who will want to talk, I will give you go ahead to talk to Doctor for any question or clarification. Thank you.
Okay.
Yes. Before someone comes in, there is one question raised in the comment section from Lamin Maro, and according to Lamin, doctor, it reads: patients that were asymptomatic and are not put on any medication, how did they recover? It's a question coming from Lamin Maro, doctor.
Yeah. So like I said in the beginning of the presentation, I said coronavirus is just like any respiratory illness viruses. Just like common cold, sometimes even if you don't put on any medication with our regular fluid intake, probably painkillers when we have joint pains, we usually clear the virus on our own. So the same thing I think is happening here. Even if you don't put on the medication, they clear the virus on their own. I think, yeah, that's the case.
Hello, can I
Thank you
comment?
so much. Yes, go ahead.
Yeah,
yes, thank you, Dr. Njai, for the presentation. I just wanted to make a small comment on this last question. Said without treatment, they recover. I mean, the question I was asking. So I just remember one of what my professor used to say about flu. With treatment, it lasts for a week. Without treatment, it lasts for 7 days.
Okay.
Which technically is the same thing.
Yeah.
So yes, generally, like you said, COVID-19 has no laid down treatment plan, especially if they are asymptomatic. And in case of asymptomatic, it's just symptom treatment. If they don't have any symptom, by asymptomatic mean they don't have any symptom. And by symptomatic treatment mean you are treating the symptoms. So generally for those who do not understand, it's because they do not understand. But if a patient comes, is tested positive and has no symptom, all you need to do is to make sure that they are not a threat to general society. And that is why we are not leaving them in their homes. In Europe and other places where somebody lives alone, they can actually be kept home.
In their homes,
But just to make sure people understand that the fact that they are in a treatment center, being given medication doesn't mean they are not getting treatment. They are being followed. They are being psychologically talked to, and they're actually being prepared. So you have reduced the risk from the community by bringing them to a treatment center, one, and you're following their symptoms.
Exactly.
So if they get any symptom, it is treated. If there is no symptom, it is left alone. I mean, you don't change what has no problem. So people need to understand. I think the general population needs to be taught to understand that asymptomatic is a danger to the general society, and bringing them to the treatment center, it's better for the general society. And if they develop any symptoms at the treatment center, it will be treated. If they do not develop any treatment, any symptoms, they're still very safe, but there is a treatment team around and a psychological support to help them understand that they have a condition that could be a problem for the general. So what I would like to ask, just a general comment, would be on the state of public emergency, the lockdown that we are seeing and intermittent. So based on the number of cases we have in the Gambia, knowing that there is limited or no, at least there is no local transmission, what do you think should be the government approach or the policy approach to the state of emergency? Do we open and go back to normal, or do we do an intermittent, open and close?
I think if we completely open now, that will be of more complications. From my point of view, this is my personal point of view, I think we can relax the restrictions internally, but we still must control our borders, because like I said in the presentation, almost 80% of all the people we are having are coming in the country from Senegal. And this is, interestingly, this is even after the lockdown. Now you say your borders are closed, people are still coming, so there is something. So I think we need to concentrate on that area, and internally we can reduce the restrictions. So I always tell people, not even about the COVID-19, but there are other respiratory diseases that we can get from each other by coughing and sneezing. So that social distancing, that hand washing, should be something that we must continue to maintain. That is something that is very, very important for ourselves. Thank you.
All right. Thank you so much. Thank you, Dr. Ba, and as well, Dr. Njai. We thank you both. And yes, this is a question from Bubakar Jallo, and it reads, what efforts are being made to open treatment centers in the peripheral region in case that the epidemic is blown out of proportion? I think just to summarize it, in the worst case scenario, are there any possibilities of, let's say, extending the case management treatment center to other regions of the country? What's your response?
Yes. There's definitely. That is definitely something that is already in the making. So if you look at like region, every region, there's a place that is identified to say this place can be turned into a treatment center as soon as possible. Already some are being worked on renovations and others, but like in Soma Health Center in LRR has already been identified. In the North Bank, Jabakunda Health Center, Bansang Hospital also have a place that is already identified. And in URR, Sabi Health Center, and in the URR North Bank, then we have the Yorubawal Health Center already identified. So these are places that we already identified. In case there is a surge, you can just move all the patients from this place. Like let's say in Sabi, you move all the patients from Sabi to Basse and use Sabi as the treatment center. So Yorubawal, you can move everybody to Bajakunda and use Yorubawal. So that's how the plan is as of now.
Okay, that's fine. This is just a personal follow-up question. So are there some, let's say, infrastructural wise, are there anything that should be in place to have a functional treatment center for COVID-19? Because it seems it's a matter of switching from one center to another. So if things remain constant, does that clearly meant that literally there is no infrastructural related preparations if it is?
Yes, so we really need to improve on those ones. Like we said, what we are seeing in other parts of the world, if it comes to, because in the whole of the Gambia, we have only one ICU, that's Banjul. Now, the ventilators that were brought in are taken to the sanatorium. So God forbid if everything goes out of proportion, wherein probably the one in Basse will need intubation, then we are in trouble. So we need a lot of infrastructural and human resource, both capital and human resource that needs to be put in place. But like I always tell people, preparation is not easy. And as a third world country, it's going to be very difficult to be prepared. We have seen advanced worlds like Moscow, Russia, America, China, Italy being overwhelmed by this. So let's just pray that it has not come to that percentage of the population that was infected that comes to our area. So if those people with all the powerful muscles can be brought to their knees, I think Gambia, we just have to make sure we be thanking God.
Yeah, all right. Thank you so much. Now back to Babu Karlum. I think we're done with specific questions in the chat section. Let me see, probably. Yes, something just pops up now. Let me quickly do that, Babu, before handing over. This question is going out to Doctor, and it reads from Babu Karboy. Given that there is too much psychological stress for taking positive cases at the treatment center that do not manifest signs and symptoms, how about establishing isolation centers for such cases rather than taking them to the treatment centers? What's your take on that? Sorry if this is covered, I'm just joining the meeting. It's coming from Babakar Boy. Doctor, you may have something to say.
Yes, I think what he said is something very, very important. This is something that we have all been thinking. But then, like I said, the provision of another center again, because what happened if only on isolation, we look at what we do in the sanatorium, like we do their 6-hourly vital signs to see their temperature and other parameters. So if we take them to another place, probably maybe you need more human resource also to take care of that place. Now, if you go to quarantine, example, you have the public health officer, you have the nurses, they're also busy checking their vitals, daily. So if you want to open another one, it's going to be a problem. So I would have agreed if we have very sick people, example, in sanatorium, and then we have mild cases coming in, I would have recommended to say, oh, let's try to separate them from the same place. But even at the sanatorium, we have different areas. Now, where we are putting our patients now is 10 rooms. We have 10, each a single room with your own toilet inside, with your everything inside. You have your TV inside, you have your satellite, they have access to Wi-Fi, every single room. Now we have another big hall where we said, okay, this is going to probably be an ICU, and that's about almost 30 bed space in the main hall. So if, God forbid, we have cases that will need intubation, will be on oxygen, will be on this ICU management, then those people are going to be moved there. But even as of now, all the patients we have were all put in their single rooms at that place, and they were all fine. Sometimes in the evening, everybody will just be sitting on the veranda, and they will be talking to each other, So I don't think it has come to that yet. But when we have cases where people are very sick, you cannot put them on people who are very sick next to people who are not very sick, and they are telling them that this is the disease you have. So, I mean, that will be a problem. We have not come to that. But I think when that happens, we have to really separate them from different places.
All right. That is very good. Thank you so much, Doctor. Now, I will hand over the baton to Babakar Lum, the moderator for the session. Since we've exhausted the question section in the, Yes, Biran.
All right. Thank you very much, Ahmad Baro. Thank you very much, Dr. Njai. I would also want to thank all our followers to say, keep on following this program. We will be bringing you more interesting content. Our experts like Dr. Njai will be available here every week to give you their expert opinion and professional opinion regarding matters that will be discussed. Dr. Njai, once again, we would like to thank you very much. I think you have done more than justice to the topic that has been assigned to you. Your depth of experience and expertise has manifested. You can also see from the questions that are coming from the audience that we have a very diverse group of people who are following the program. And as always, we endeavor to make sure that we bring you the very best of content. Until we come over next week, it was the Epi Hour team. Ahmad Baro, you are given the opportunity to close the show.
It seems Biran Ture is struggling. Probably if you can hear me out, maybe this can be an opportunity for you to ask or probably to clarify something that you will want to. Biran Ture, after which we will give a final conclusive remarks and then, yes. Biran, can you hear me? I think he almost wanted to say something, Lum, while you were, okay, so in the absence of that, I will want to take this opportunity once again, of course, to appreciate Dr. Njai for coming on board and staging such amazing deliberations. Of course, case management is a very timely and of course, it's a very strategic topic at this particular point in time. And you've definitely done justice to the topic. We are left with no option but to recognize your effort and also to appreciate you for what you've done to the topic. You've done justice. Now to the audience as well. This is your weekly Epi Hour series. And of course, you are reminded that there is a YouTube channel for that. The video will be uploaded for every segment and you can follow up. And of course, we'll be working on some other line of series that will be a bit different along the line. So this is among one of the most amazing platforms that we can assure you in terms of quality of content and of course we strategically choose for them. So until we come on your way next Friday, the same time with another very amazing presentation. Doctor, thank you so much finally, and then we appreciate your time.
Thank you very much.
All right, bye-bye.
Thank you.
Yeah. Okay.